Okay, I think it's time to start. It's 1 o'clock now, according to the clock up back of the room. You're gonna take a look up here on the screen. I have a question for you to answer. Kind of an open-ended question. There's no correct answer. So today what we're going to do is we're going to talk about some of the factors that affects blood pressure and what blood pressure is and how do you measure blood pressure. That's what we have planned for today. Okay, if you just came in and haven't answered the question, that's okay. We should have another one later. Let's take a look at what some of your responses are. I'm a little surprised because I was thinking of like a specific blood vessel. You know, well, there's one specific one up there, the great cardiac vein. That's a good answer. You know, who doesn't want to be great? You know, I was gonna say if I was a blood vessel, I would want to be either the ascending aorta or the pulmonary trunk, because both of those come from the heart. or maybe the hepatic portal vein, because it's full of nutrients. So, you know, I wouldn't be hungry if I was that one. It's full of nutrients. So all right.
Just say.
Okay, so we need to get going here because we have a lot of information to cover today. This portion of chapter 20 is concerned with blood pressure and its control, and I think this is probably the last section of chapter 20 we need to cover before our second exam. So blood pressure can be defined as the force exerted by blood on the walls of blood vessels. There's two different types of measurement of blood pressure. The first, which is probably the least common of the two, is a direct measurement, and this is most commonly done in research, like using research on blood pressure on laboratory animals. The way you directly measure blood pressure is by placing an arterial cannula, which is essentially like a hollow needle, like a hypodermic needle, directly into an artery, and then connecting that needle to a manometer, which is basically a U-shaped tube that has some kind of fluid or mercury in it, and the pressure exerted by the blood on that column of mercury will push it up a certain number of millimeters, and that's the most direct way of measuring blood pressure. Not very practical to do that, though, in a clinical situation. For obvious reasons. You have to stick a needle in an artery which has the potential to be dangerous. It's very invasive. okay? So more commonly, indirect measurements are used. The most indirect way of measuring blood pressure is with a sphygmomanometer. Okay? Sphygmomanometer is the use of a blood pressure cuff that you place around a person's brachium. I just had this done this morning because today we had some health screening that we're required to do for our health insurance purposes, so I had to get up early this morning to do it. Anyway, you can see up there, and many of you are probably familiar with this. I'm sure everyone has had their blood pressure taken manually, probably at least one time or another. You place a cuff around, or a collar around the brachium, and then there's usually a rubber bulb attached to a hose that's attached to the cuff. You squeeze the rubber bulb and you inflate the cuff. What that does is it cuts off the flow of blood through the arteries in the brachium. And then the person that's doing the manual blood pressure determination puts a stethoscope right over the cubital region of the arm. That's the area right on the anterior side of the forearm. And listens for the blood to start flowing through the arteries as the pressure is slowly released. So you listen to the sounds produced, the blood flowing through the arteries in the arm. You gradually release the pressure, and when the pressure drops far enough in the cuff to allow the blood to go through the arteries, you can hear the blood kind of spurting through the arteries with the stethoscope. Okay, that first time you hear the sound of the blood going through the arteries, that's called the systolic pressure. That's the pressure of the blood during systole, which is ventricular contraction. Then the person continues to release the pressure in the cuff until you no longer can hear blood pulsing through the arteries. That's when you end up with laminar flow, and you can't really hear much then with the stethoscope. And at that point, when you no longer hear the pulse, that's the diastolic pressure. Diastolic pressure is the pressure of the blood during diastole, which is the main phase of the cardiac cycle when the ventricles are relaxing. So usually blood pressure is expressed as a fraction of one number over the other. The number in the numerator is called the systolic pressure, and that averages about 120 millimeters mercury in a healthy person. The bottom number, or the denominator of the fraction, is the diastolic pressure. That's the pressure during diastole, and that averages about 75 millimeters mercury. Okay. Now, another important pressure in physiology is the pulse pressure. I don't know if the pulse pressure is used that much clinically, but it is used in physiology. The pulse pressure is the difference between the systolic pressure and the diastolic pressure. Now, the reason the pulse pressure is important is because by knowing the pulse pressure, you can calculate what's called the mean arterial pressure. The mean arterial pressure is the average pressure over the course of an entire cardiac cycle. Okay? So, as it turns out, the mean arterial pressure is actually closer to the diastolic pressure than the systolic pressure. So it's not halfway between the systolic and diastolic pressure. It's about 1/3 of the way from the diastolic pressure. So the way you calculate mean arterial pressure is by starting with your diastolic pressure measurement and then adding to that 1/3 of the pulse pressure. And the pulse pressure, remember, is the difference between the systolic and diastolic pressure. That gives you the average blood pressure over time. So what that does essentially is it reduces two separate blood pressures into just one number. And if any of you are doing experiments in lab that are involving blood pressure, that may be something you may want to do. Instead of recording systolic pressure, well, you're going to want to record systolic and diastolic pressure. But if you're looking at a factor that might affect that, rather than separately analyzing the systolic pressure and the diastolic pressure to see if there's any change, you may want to convert the systolic and diastolic pressure to the mean arterial pressure. That way you only have one number you need to analyze. And you can look at the effect of a factor on just the mean arterial pressure over time instead of looking at systolic and diastolic pressure separately. Right? So that's one reason why you might want it. But the mean arterial pressure is just basically kind of the average blood pressure over time. And mean arterial pressure influences the risk of certain problems such as fainting if your blood pressure gets too low. There's a condition called atherosclerosis where you get lipid deposits building up in the walls of arteries, which can narrow the arteries. If you narrow the artery, it's going to increase peripheral resistance, and that's going to increase blood pressure. Kidney failure, edema, which is accumulation of fluid in tissues, and the possibility of an aneurysm. We'll talk more about some of these problems later. Aneurysm is when the wall of a blood vessel gets weakened. If you have high blood pressure, the pressure of the blood may cause the wall of the blood vessel to balloon out, just like blowing up a balloon. And if that wall gets to the point where it gets so weak that it ruptures, then it can cause internal bleeding, and a person could potentially bleed to death. So aneurysms are very dangerous, and the threat of getting an aneurysm increases as blood pressure increases. The higher the blood pressure, the more likely that a blood vessel will end up getting blown out. All right, so the other day I showed you an equation that described the two factors that affect cardiac output. This cardiac output is equal to heart rate times stroke volume. Okay, that's an important relationship to remember. A second important mathematical relationship is the one that you see up here. Mean arterial pressure is equal to cardiac output times peripheral resistance. Now, the reason that this relationship is important to remember is because that will remind you of the two factors that affects mean arterial pressure, which is the average pressure over time. Okay? So you can increase mean arterial pressure by either increasing cardiac output or by increasing peripheral resistance. Or if there's a great increase in demand for blood and you need an increase in blood pressure to meet that demand, you could increase both of those factors, both cardiac output and peripheral resistance. Okay? So why would your body have a need to do that? I mean, don't you want your blood pressure to be relatively constant? What kind of situation would you want to have an increase in mean arterial pressure? I can think of quite a few situations where you might need that to happen. What if a person got in an accident and they lost a lot of blood and they were hemorrhaging? What's that going to do to their blood pressure? If they get in an accident, their blood pressure is going to go down. If you lose a lot of blood volume, your blood pressure is going to start falling. And if it falls too far, you can go into shock. Okay, so that's one situation where you want to increase mean arterial pressure to bring it back up to normal. As your blood pressure falls too low, you're going to have a decrease in blood flow to vital organs. And if it decreases too much, those organs are going to start to fail. So your body needs to increase mean arterial pressure sometimes just to maintain homeostasis if blood pressure falls too far. Or you could look at this just the opposite. This also can tell you what you would have to do to bring blood pressure back down if it gets too high. If blood pressure gets too high, you could decrease mean arterial pressure by either decreasing one or both of those factors, either decreasing cardiac output or by decreasing peripheral resistance. Okay, so you can use this relationship. There's quite a few different questions you can use this to answer if you know that relationship. Okay. So question up here says, what is the effect of increased sympathetic stimulation on those two factors? Okay. Would sympathetic stimulation affect both those factors or just one? Or none of them? Would sympathetic stimulation increase cardiac output? Yeah, it would, because sympathetic stimulation increases heart rate and stroke volume, both, by increasing contractility. So sympathetic stimulation would cause cardiac output to go up, and it would also increase peripheral resistance because there's sympathetic inputs to blood vessels as well that will cause vasoconstriction. And that will increase peripheral resistance. In turn, that will cause an increase in blood pressure. So both of those would be affected by sympathetic stimulation. Not all blood vessels would be affected the same way, though, because during the fight or flight response, blood flow to digestive organs is decreased. So, and blood flow to skeletal muscles is increased. So it depends on what blood vessels you're talking about. But it is going to, in general, cause an increase in peripheral resistance. Now, there's two relatively common disorders of blood pressure that are both kind of they're both kind of correlated with age. The first one is called arteriosclerosis. Arteriosclerosis is one of those things that just kind of happens with increased age. As you get older, your arteries lose their elasticity. They lose some of the elastic fiber in the walls, and they become less elastic. They could become harder. And that prevents the arteries from stretching in order to relieve some of the pressure during systole, and that's going to cause an increase in systolic pressure. Okay? And if you have an increase in systolic pressure, that increases the chance of having a ruptured aneurysm, which could be in the brain or the aorta or any place. So that increases the chance of a cardiovascular incident. Another one that probably most common cause is higher than normal cholesterol in the blood is atherosclerosis. Atherosclerosis results from an accumulation of lipid deposits in the walls of the blood vessels. And that can cause a narrowing of the lumen of the blood vessel. The more narrow the lumen of the blood vessel, the greater the peripheral resistance. And so that's going to increase peripheral resistance, which is going to increase mean arterial pressure. Okay. Now, another problem that can happen with atherosclerosis is that lipid deposit can rupture into the lumen of the blood vessel. If that happens, then you'll get some blood leakage from the microscopic vessels that supply the wall of the blood vessel itself, the vasa vasorum that I referred to the other day. And that could cause a blood clot to form inside the blood vessel. If that happens in one of the coronary vessels, that can cause myocardial infarction. If it occurs in the brain, it can cause a stroke. So those are problems that there's an increased chance of if a person has atherosclerosis. Not to mention high blood pressure, which is also known as hypertension. Hypertension refers to higher than normal blood pressure. Chronic hypertension is considered to be a blood pressure greater than 140 over 90. Okay? And that can weaken small arteries, and that can increase your chances of having an aneurysm. If you look at this, this MRI over here, MRI image, you can see a big bulge on the right-hand side of the aorta. That's an example of an aortic aneurysm. And unless you do something like an MRI like this, a person may never know they have an aneurysm until it ruptures. But once it ruptures, it's almost too late because there's really that. If it was an aneurysm of the aorta, it's going to cause some major internal bleeding, and that could cause a person's blood pressure to fall very quickly. They could go into shock and die. So aneurysms are, they're sort of a silent killer because most people don't know they have them until it's too late. The opposite of hypertension is hypotension. That's chronically low resting blood pressure. That can be caused by blood loss, dehydration, or by anemia. All right, now there are a variety of mechanisms that help to regulate blood pressure so that it neither gets too high or too low. So these are homeostatic mechanisms, and they all work by negative feedback, just like most other homeostatic mechanisms. One of these mechanisms is called local control. That's actually, local control is a whole, it's kind of a collection of mechanisms that act directly on the blood vessels that supply tissues. And one of these forms of local control is called metabolic autoregulation. And autoregulation of blood flow occurs if tissues start to become hypoxic because there's insufficient oxygen. That could be as a result of a lack of sufficient blood flow. So if you don't get enough blood flow to tissues, metabolic wastes start building up, like lactic acid and carbon dioxide and hydrogen ions and potassium ions and adenosine. So those metabolic byproducts, most of which are from anaerobic metabolism, those directly affect the smooth muscle in the walls of the blood vessels that supply those tissues, and causes so those chemical factors cause vasodilation of the smooth muscle, and that's a direct effect on the walls of the blood vessel that doesn't involve any stimulation by the autonomic nervous system. In addition, other chemicals like histamine that can be caused by inflammation, bradykinin, and prostaglandins stimulate vasodilation due to trauma, inflammation, or exercise. So that's a direct effect on the blood vessels that can, if there's not enough blood flow, then metabolic byproducts will build up, and that will cause vasodilation, which will increase blood flow. Another mechanism that can cause a change in blood flow is called reactive hyperemia. Reactive hyperemia occurs when blood flow is temporarily, it's when blood flow is increased above the normal level after the supply of blood to an area has been decreased, and then restored. Okay. One example of reactive hyperemia is if you go outside in the winter, and when you go outside, your blood vessels that supply the capillaries near the surface of your skin become vasoconstricted, and that decreases blood flow to the surface of your body. And when that happens, if you go outside for a long period, that's going to restrict blood flow to your skin. And so metabolic byproducts are going to start building up in your skin. So then when you go inside, your face looks red. It's more flushed because those metabolic byproducts cause vasodilation and cause an increase in blood flow. Okay, that's called reactive hyperemia. You do the same thing if you just say put a ligature around your wrist and decrease blood flow to your hand. If you do that for, you wouldn't want to do that too long, but if you do that for, let's say a couple minutes and then release the pressure, your hand sometimes will get more kind of red because the metabolic byproducts that build up due to a lack of blood flow are going to cause vasodilation, which increases blood flow. Now, over the long term, there's a long-term mechanism that helps to increase blood flow to a part of the body that's not receiving oxygen, and that is through the growth of new blood vessels. If there's insufficient blood flow for a long period of time to a part of the body, that lack of blood flow will stimulate the growth of new blood vessels, which is called angiogenesis. And that can cause the growth of arteries that bypass obstructions in the coronary circulation of the heart. Okay, so it's a way of recovering from like a heart attack. But angiogenesis can occur anywhere in the body. Angiogenesis refers to development of new blood vessels. Now, there's also neural control of blood pressure. And neural control is probably some of the most important mechanisms that can regulate blood pressure because your nervous system can react very quickly to changes in blood flow. It can return blood pressure, can maintain homeostasis of blood pressure. So the part of the brain that regulates blood pressure is located in the medulla oblongata along with the cardiac center and the respiratory center. There's another center called the vasomotor center. The vasomotor center is what regulates blood pressure. And there are 3 different reflexes that have input to the vasomotor center and can regulate blood pressure. These 3 reflexes are called the baroreflex, the chemoreflex, and the medullary ischemic reflex. Those are 3 different reflexes that can regulate blood pressure by either bringing blood pressure back up or bring it down, depending on which way is necessary to maintain homeostasis. So let's start first with the baroreceptor reflex. We've probably looked at this one before at the beginning of the first semester of anatomy and physiology. I think I use this as an example, as one example of a negative feedback system, because all these reflexes work by negative feedback. So like any negative feedback system, the baroreceptor reflex has sensors. These sensors can detect changes in blood pressure. And there are two different locations where these sensors are found. Some of them, and these sensors are called baroreceptors. Baroreceptors monitor blood pressure via the amount of stretch in large arteries. And the two places where these baroreceptors are located are in the aortic arch. That's one place. There's aortic baroreceptors there. And the other place is in the carotid sinuses. Carotid sinuses are located right below where the common carotid artery forks to form the internal carotid and the external carotid arteries. So that's located right up here, right at the very top of the neck. Okay? So there's sort of a dilated upper part of the common carotid artery. That area is where the carotid baroreceptors are located. And so those baroreceptors, as I said, respond to stretch. So if blood pressure increases, the common carotid artery is stretched out more, and that stimulates the baroreceptors. Baroreceptors respond by increasing their rate of firing of action potentials, and those signals travel from the carotid baroreceptors to the vasomotor center in the medulla oblongata via the glossopharyngeal nerve. Likewise, the baroreceptors in the aortic arch, when they stretch, they increase their frequency of action potentials that they produce, and those signals are carried by the vagus nerve to the vasomotor center in the medulla oblongata. Okay, so that provides input to the vasomotor center concerning the amount of blood pressure, about the pressure of the blood. So, if blood pressure gets too high, then the vasomotor center responds by decreasing sympathetic stimulation to the heart and to the blood vessels, and increasing parasympathetic stimulation of the heart. So that does two things. One of them, by decreasing sympathetic stimulation of the heart and increasing parasympathetic stimulation of the heart, that brings the heart rate down. When the heart rate goes down, cardiac output goes down. Cardiac output is one of the two factors that affects mean arterial pressure. So that in itself is going to cause blood pressure to go down. But there's more, because the vasomotor center also sends out signals to all of the arteries in the body. And that, so the vasomotor center would decrease sympathetic stimulation to the arteries, which would cause vasodilation. When the diameter of the arteries increases, that decreases peripheral resistance. Peripheral resistance is another factor that affects mean arterial pressure. So both peripheral resistance and cardiac output decrease, so that's going to cause a decrease in mean arterial pressure. Okay. So that's what happens if blood pressure increases. Now, if blood pressure falls too low, then just the opposite occurs. If blood pressure is too low, the baroreceptors aren't stretched as much, so they decrease their rate of firing of action potentials. That decreased rate of firing is relayed to the vasomotor center via the vagus and the glossopharyngeal nerve, which are cranial nerves 10 and 9. And the vasomotor center then responds by increasing sympathetic stimulation to the heart and blood vessels, and decreases parasympathetic stimulation of the heart. Most blood vessels are not supplied by parasympathetic fibers. They're only supplied by sympathetic fibers. So the diameter of blood vessels can either be decreased or increased just in response to changes in sympathetic stimulation. The heart, however, is supplied by both divisions of the autonomic nervous system. So if blood pressure is too low, you get an increase in sympathetic stimulation of the heart. That's going to increase both heart rate and contractility, which increases stroke volume. That's going to increase cardiac output. And the increased sympathetic stimulation of blood vessels is going to cause vasoconstriction, and that increases peripheral resistance. So both factors that affect blood pressure are going to increase, so that'll bring blood pressure back up. Since this is controlled by the nervous system, and the nervous system can react very quickly, this can allow for very rapid adaptations to change in blood pressure. Okay. So this is probably the most important mechanism that's involved in regulation of blood pressure. Okay. Any questions? So you really should commit this reflex, I think, to memory. There's likely to be some questions about this on the second exam. All right, now in addition to input from the baroreceptors, there's actually input to the vasomotor center from higher brain centers. So if a person experiences stress, if you have a lot of tests during the week during school, or if a person is angry, or if you're just really overstimulated, aroused, there are inputs from higher brain centers to the medulla oblongata, and so some of that activity of higher brain centers can also affect can affect blood pressure by stimulating the vasomotor center. Also, the vasomotor center can be stimulated in response to exercise or changes in the body temperature. If body temperature increases, the hypothalamus can send a signal to the vasomotor center, which can cause an increase in blood pressure. All right, so this is a little animation that I found that goes through this reflex again, so you can listen to another person describe the pathway, the reflex arc that regulates blood pressure.
Increased blood pressure stretches the carotid arteries and aorta, causing the baroreceptors to increase their basal rate of action potential generation. Action potentials are conducted by the glossopharyngeal and vagus nerves to the cardioregulatory and vasomotor centers in the medulla oblongata. As a result of increased stimulation from the baroreceptors, the cardioregulatory center increases parasympathetic stimulation to the heart, which decreases the heart rate. Also, as a result of the increased stimulation from the baroreceptors, the cardiovascular center decreases sympathetic stimulation to the heart, which decreases heart rate and stroke volume. The vasomotor center decreases sympathetic stimulation to blood vessels, causing vasodilation. The vasodilation, along with the decreased heart rate and decreased stroke volume, bring the elevated blood pressure back toward normal. If the initial problem were a decrease in blood pressure, the activities and effects of the baroreceptors, cardiovascular center, and vasomotor center would be the opposite of what is illustrated.
All right. Okay, now, a second mechanism that also can affect the vasomotor center of the medulla oblongata are chemoreflexes. Now, chemoreflexes actually mainly are involved in regulation of breathing. The chemoreflexes can cause an increase in breathing or a decrease in breathing, but those same chemoreceptors that are involved in the chemoreceptor reflex also have inputs to the vasomotor center in the medulla oblongata, so they can also affect blood pressure. So hypoxia, extremely low oxygen levels, these chemoreceptors are in the same place as the baroreceptors, by the way. They're in the aortic arch and they're in the carotid sinuses. The chemoreceptors are actually more sensitive to changes in pH and changes in carbon dioxide levels than they are to small changes in oxygen concentration. In fact, those chemoreceptors are only stimulated by changes in oxygen levels if oxygen levels fall very, very low, if they're critically low. They're not really affected much by smaller changes in oxygen. So anyway, hypercapnia, which is elevated CO2 levels, acidosis, which is caused by low pH, caused by an excess of hydrogen ions. Those stimulate the chemoreceptors in the aortic and carotid bodies and send signals to the vasomotor center. So if you have very low oxygen or higher than normal CO2 levels or higher than normal hydrogen ion concentrations in the blood, that will stimulate the chemoreceptors. They will send signals to the vasomotor center, causing an increased sympathetic stimulation of the heart and blood vessels, and a decrease in parasympathetic stimulation of the heart. That will cause an increase in heart rate and stroke volume, both of which will increase cardiac output. Cardiac output then in turn affects mean arterial pressure. The increased sympathetic stimulation of blood vessels causes vasoconstriction, which increases peripheral resistance. That will increase blood pressure as well. According to that equation, mean arterial pressure is equal to cardiac output times peripheral resistance. So if you have an abnormally low amounts of CO2 in the blood, and if you have abnormally high pH, then just the opposite will occur. Then the stimulation of the vasomotor center in the brainstem will be decreased from the chemoreceptors, and so you'll get a decreased sympathetic stimulation of the heart and blood vessels, an increased parasympathetic stimulation. That will result in an increase in blood pressure. Let's see. If you have lower than normal CO2 levels and a higher than normal pH, yeah, that'll slow down the heart. That'll slow down the heart. It'll cause vasodilation of the blood vessels. That'll cause a drop in blood pressure. It'll cause a drop in blood pressure because if your CO2 levels are lower than normal, that means your cardiovascular system is tearing away the CO2 fast and getting rid of the hydrogen ions, so you don't need as much blood flow. So by decreasing blood pressure, that helps to decrease blood flow. It allows CO2 and hydrogen ions to build up to normal levels. In addition, the main function though of those chemoreceptors is to stimulate the respiratory center. So if you have a lower than normal oxygen concentration, like very low oxygen concentration, if you have higher than normal CO2 levels or higher than normal hydrogen ion concentration in the blood, that will also stimulate respiration. That helps you to take in more oxygen and to blow off more CO2. By blowing off more CO2, that helps to lower the hydrogen ion concentration in your blood as well. So the main effect is on the respiratory system, but simultaneously it also affects the cardiovascular system. Okay. Then, finally, the third mechanism is the medullary ischemic reflex. The medullary ischemic reflex doesn't operate very often. In fact, in the average person, it probably never really kicks in ever, unless you have a restricted blood flow to the brain, okay? So if someone's being strangled by someone else, this medullary ischemic reflex will kick in order to return blood flow to the brain. So the way this works is that anytime blood flow to the medulla oblongata, which is the brain stem, which in a way is the most important part of the brain because that's what controls breathing and blood pressure, and it controls the heart. Anytime blood flow to the medulla oblongata is decreased, both the cardiac and the vasomotor center increase sympathetic stimulation of the heart and decrease parasympathetic stimulation. And so that can greatly raise blood pressure in an attempt to restore blood flow to the brain. Okay. And I actually saw a demonstration of this, believe it or not, when I was in graduate school. It was in a human physiology class at the school I went to for graduate school, which was at Idaho State University. Our physiology professor that was doing this demonstration, it was in lab, was doing research on arterial transplants in dogs. He's using dogs for a laboratory animal. And so he demonstrated this medullary ischemic reflex. What he did was he anesthetized the dog, and then he tied a ligature around the carotid arteries of the dog, and then tightened the sutures around the common carotid arteries of the dog, basically cut off blood flow to its brain. And while he was doing this, we were monitoring the blood pressure of the dog. And as soon as he cut off the blood flow to the brain through the carotid arteries, the blood pressure of the dog shot up. And so it was he didn't cut off the blood flow to the brain so long that it caused brain damage to the dog. He only did it for probably less than 10 seconds, but in that short amount of time, the blood pressure of the dog went way up, and that was caused by that medullary ischemic reflex. Okay, so in addition, over the long term, blood pressure can also be regulated hormonally through hormones that affect blood volume. And this is mediated mainly through the urinary system, because there's hormones like aldosterone that's produced by the kidneys that can regulate blood volume. If blood volume increases, blood pressure increases. So if your blood pressure is too low, as is chronically low, eventually hormones will be released which will cause your kidneys to reabsorb more sodium and more water. That will increase blood volume and increase blood pressure. So this is a longer term form of regulation, though, that regulates blood pressure over a longer term. And blood volume is increased through an increase in reabsorption of water. Water always follows sodium, though. So that's one of the reasons why it used to be anyway, that if you had high blood pressure, doctors would recommend that you go on a low sodium diet. Because the more sodium you have, the more water you reabsorb. Doctors have now kind of reversed course on that. They think most high blood pressure is hereditary, and it's not caused by too high of sodium levels. So some doctors still, though, tell patients to restrict their sodium levels. So there may still be something to it, but in a lot of cases just hereditary. All right, so. All right, well, we're going to have to stop. We're out of time, so we'll finish this up on Friday, and it should give us some time for review.
Thank you.